The broadcast is now starting. All attendees are in listen-only mode.
Okay, we ready to go? Thank you so much for coming and joining us. And Clay's given us kind of a overview of how many are joining. So I really want to thank you for taking your time on Sunday afternoon to be a part of this. And I do want to open prayer, but before I do that, just a little bit of kind of rules of engagement, I guess, is you'll be able to write in questions on the chat, and we'll try after each little presentation to answer some of those. But if it starts going too long, then we'll just go through the presentations and answer what we can at the end. The other thing is we really want to present some facts about what's going on in the state and what we'll be doing as a church, rather than going through political views of what you think should be done or what you think has happened. We're just going to state what has happened. Kind of the way all of us wish the news should be, but the way the news often isn't. And then finally, I want to say, I was talking with Tom Lamblett, pastor most of us know today, and we were just talking about the difficulties of this whole season and this topic and in reopening. And it ended up bringing us both back to the first heart attitude of the old Cottonwood Church, which is a heart attitude at AnchorPoint. And that's, I'm going to put the goals and interests of others above myself. And I think that is where we need to be as a church, and that's what we want to do as a church. So things that we'll be talking about that we are doing as a church, you may feel like are unnecessary, or you may not even agree with. But the question is, can I put the goals and attitudes of others above my own? Can I care for them most? And, Paul says, I won't even eat meat again if it's going to cause you to sin or stumble or not go to church. So how can we do church in the best way possible, not for us, but for others? And so I hope that can be our picture going forward. How can we learn about what's happened? How can we care about others as believers? So that's kind of the framework of where we're at. So I'm going to open in prayer, then Clay's going to talk about what's going on in New Mexico, what has happened and where it looks like we're going from here. Cole's going to cure the whole problem after that, with a little talk on vaccines and some other things. And Clay's can talk about the new government order after that. And then Chris and I may jump in a little bit. We'll talk about our policy as a church going forward, how we're going to open up, how we're going to try to care really for the most vulnerable among us, how we can get the gospel out, be the best example that we can in our community and in our church. So Heavenly Father, I thank you for caring about us. I thank you for being with us. I thank you that we can be a group of people who may have different thoughts on a whole lot of what's going on, but that all of us can come together and put your love for others first. So Father, we love you and we love others, and we ask that you would help us to be able to do that in a real practical way, and that you give us wisdom as we look at what's going on in the state and in our church, that you could just really be pleased one day in glory and say, hey, you did that COVID thing right. In your name we pray. Amen. So Clay, you are up.
Amen. Thank you very much, Dan. Looks like we've got about 24 people. So just a small portion of the church today. We're going to record this webinar and hopefully make it available on the church website. And I hope that it will be just instructing for people just to see what are the facts on which the elders are making decisions, and what are the facts on which the public health orders are being issued by our governor in our state. So, as of 5/16, as of yesterday, there were 5,847 positive cases in the state of New Mexico, with 259 deaths. Something that's interesting is that it's not hitting New Mexico in a consistent or equitable manner. Of those 5,847 deaths as of yesterday, 3,106 were attached to a tribal entity, a Native American, and very, very heavily pushed over towards the Navajo. That's 53% of the deaths of the positive cases in New Mexico have been affecting our Native tribes. It's also not equitable in the way the deaths have been spread, with half of the deaths being happened in confined populations in nursing homes and assisted living facilities. And so A lot of us, I think, sit and think about what are the odds that I could both contract COVID and be hospitalized or die from COVID. And really, in my mind, that's not the question that many of us are grappling with. But the question is, how will my actions affect those who are most vulnerable, and how will my actions affect the capacity of the state to care for the most vulnerable? So my role in civilian life is I am the Executive Vice President, Chief Operating Officer for Presbyterian Healthcare Services, and we serve a safety net for the state of New Mexico. There's some things that have happened since March 10th, when the first public health orders were issued, that I never thought would happen in my career. And one of them is that Troy Greer at Loveless and Kate Becker and Mike Ciccarelli and Mike Richards at UNM actually embedded their operations at Presbyterian along with the Department of Health and Secretary Scrace. And we all have been working with all of our assets at each other's disposal with one central command in order to meet the needs of the state. And I think while a lot of us have been sitting at home for an unreasonable amount of time, and we've seen just unbelievable sacrifice being made by our businesses, by our economy, by our schools, we kind of think nothing's happening. And we look at the curves, and we all have our favorite websites. What I want to tell you is thank you for staying home. The ICUs in central New Mexico have been absolutely full. In fact, up to this time last week, UNM, Presbyterian, and Loveless were about 20% over our licensed capacity for ICU beds. Beginning about 10 weeks ago, we all began putting in contingency plans where we canceled elective surgeries, and we began turning the pre-op and post-operative bays into ICU beds, and we began retraining pre-operative, post-operative, intraoperative staff and anesthesiologists to be critical care staff. It's been just an insurmountable accountability to think of how you're going to care for the state when the models we're projecting are complete overwhelming of the hospital systems, like we saw in New York, like we saw in Seattle early on. And it was really the actions of people who were willing to shut down their businesses and willing to stay home that changed those predictions pretty dramatically. And we can see week by week, order by order, behavior by behavior, region by region, where that worked and where that didn't work. Just some numbers for today. First, there are very few ICU beds in the state of New Mexico. In normal times, there are 365 licensed ICU beds in the state of New Mexico. For a state of 2.1 million people, there are 365 ICU beds. That may be shocking to some. Generally, out of acute care hospital beds, around 10% are reserved for intensive care. And frankly, those beds are not equal in capability, and they're not equal in staffing. And so what exists in what we've identified as 7 hub hospitals or ICU receiving hospitals in the state of New Mexico is very different than what exists in the rest of New Mexico. So 275 of those 365 licensed ICU beds in our state, or about 75%, are staffed by critical care physicians, have critical care certified RNs, have ventilators, are used to handling multiple drips, are used to handling respiratory illness of the severity of a COVID-19 infection. We early on identified 7 hub health systems across central, northwest, eastern, and southern New Mexico. And in those 7 hub systems, we were able to take 275 licensed ICU beds, and through methods like expanding into perioperative space, GI labs, procedural space, we were able to put a plan together to expand to 613 total ICU beds. That is actually moving standard of care, though. That's not everyday care that we provide with one nurse for every 1 to 2 patients, with a board-certified critical care intensivist monitoring with standard ventilators. If we went from 275 to 613, that would be what we call crisis standard of care. That would be maybe 2 patients on 1 ventilator. That would be a team of nurses that aren't used to caring for the ICU under 1 experienced ICU nurse. It'd be anesthesiologists instead of critical care physicians. We hope we never get to that point. We haven't gotten to that point yet. But we have gotten about 20% above our conventional standard of care. So we're in a place right now between conventional and crisis that I would call our contingency standard of care, where we're using unusual locations for care. We're using some team care models. We're training up new staff to provide care, but we're still able to keep conventional ratios of staff and conventional tools like ventilators in use. Today, across the 250, across the ICU beds in the licensed hubs, there were 258 of the 275 beds filled. It's not equal. Down in Las Cruces, the ICUs are 40% empty. Over in eastern New Mexico, the ICUs are about 11% empty. Up in the northwest, San Juan Regional is 14% over its licensed capacity, and Christus St. Vincent's is 6% over its licensed capacity. UNM, Lovelace, and Press are sitting right at 100% of licensed capacity. At 7 a.m. this morning, we had 8 ICU beds in the city of Albuquerque between the 3 major health systems across 6 hospitals. 8 ICU beds available across 6 hospitals. So that's the state of what we're seeing inside of the hospitals. 58 patients as of this morning were on ventilators. And we had 8 patients that were actually on ECMO, which is when you have a complete organ replacement with external pumps, pretty serious. So as of 7 a.m. this morning, we had 17 patients holding in our emergency department at Press Hospital. We had 2 medical beds available and 5 critical care beds available and 26 telemetry beds available. And that's just to give you a picture of kind of what's been happening in New Mexico. So with that, I do want to pull over and share with you when March 10th came by and the public health orders were issued and the 3 health systems and the Department of Health began to work together to create one set of resources for the state of New Mexico. The governor formed something called a medical advisory team. It was made from those same 3 health systems, UNM, Lovelace, and Presbyterian. And it was critical care physicians and infectious disease experts and epidemiologists from the Department of Health, plus scientists from the Sandia National Labs and Los Alamos National Labs. They started to refine the models for how COVID-19 was going to uniquely hit New Mexico because of the social determinants of health, the conditions of living in rural New Mexico, and the high Native American concentration in New Mexico. They started to look at what treatments would be available, how we would create novel PPE, personal protective equipment, how we get new manufacturers up. We started to pull all the science together and feed that into the governor. I want to share with you now a couple of resources that are very publicly available where you can watch all of this happening and you can have real-time access to what we're seeing in these medical advisory teams. So I'm now, you should be able to see my screen. And where I'm taking you first is just the New Mexico Department of Health's, pardon me while I wait for this, the New Mexico Department of Health's public dashboard for coronavirus. And I'm going to take you to the launching page just so you can see this. Cole, can you confirm my screen is projecting? Okay. Sorry, I went to the wrong screen there. Boom. Okay, so on the front homepage of this, you always see the number of positive cases in New Mexico and the total tests and the positive testing rate. New Mexico is one of the top 10 states in the country for the amount of testing that's been done per capita, 128,000 tests across 2.1 million people. If you come up here to data dashboard, there is an amazing amount of data available, not just for the state, but for every region of the state. And you can click any county in the state. So for example, we can click Sandoval County, and we can see that there have been 483 cases in Sandoval County, 22 deaths, and 11,671 total tests. We can come over here. Sorry, let me move my control panel out of the way. Back to come over here and you can see the demographic breakdown, and you can see a lot of people believe that this disease is a disease of the elderly and the infirm, and actually the infection rate has a very bell-shaped curve, and we are seeing actually New Mexico is the second highest incidence of pediatric infection in the country for COVID-19. So a lot of information here. Also information, if you click up here by testing, that is available here. Take you back to the home page for this, and if you pardon me one second, if you look further down in this website, you will see clinician information. If you click on clinician information, this will give you a full view of New Mexico's pandemic plans and everything about the medical advisory teams that I just described to you. And if you click on that under MAT resources, then you will see what the medical advisory teams are telling the governor on every topic that comes in. There's a place where you can submit your own questions and they will be given to the medical advisory team. So today's the 17th. Friday's questions that were answered had to do with the Kawasaki disease and some of the pediatric complications of the inflammatory systems, recommendations on masks, immunization resources, how to prioritize the stockpile was last Wednesday, using convalescent plasma for treatment, which is being done at all of our major health systems in New Mexico now, remdesivir distribution, which Cole will speak to, which is available at all of our major health systems in Mexico. All of that is available for you right there. So I just wanted to share with you some of that. While I have this up, I also want to share with you the model, which is how we are projecting the virus to behave in New Mexico. And it is the Department of Health, Presbyterian, Los Alamos National Labs, and Sandia National Labs that work on this every week. Cole actually consulted on this, which we'll talk a little more about his qualifications later. But this is everything that's getting sent to the governor. There's some really fascinating things like a 10-fold increase in the Northwest over the rest of the state in the prevalence rates of this disease. There's some phenomenal information about age distribution, doubling times. But what I want to show you is the hospitalization rate. Forget about whether we're testing enough people. Forget about what the true transmission rates. If you just look at per 100,000 people, you're seeing that in metropolitan area, which is Albuquerque and Rio Rancho, 17 people per 100,000 are being hospitalized from this disease in New Mexico right now. And up in the Northwest, that's 159. I have a chief executive officer at a Northwest hospital who has 11 environmental service workers who have lost a family member to COVID-19, one who's lost 3 family members to COVID-19 this year. So these are transparently available. This is the actual New Mexico hospitalization rate. In the salmon color is hospitalizations without a ventilator. The green color, teal color is hospitalizations with a ventilator, and the percentage of patients with a ventilator. You see it coming down in the percentage from where it started out, almost 65%. Got a lot better at using proning techniques and BiPAP, CPAP to keep people off of ventilators, but we're still seeing 25% of hospital admissions requiring ventilation, and that's one of the things we've worked hardest to kind of address. So I threw a lot at you. My purpose, let me unshare my camera, unshare my desktop. My purpose in going through that was simply to give you awareness. This is a disease that is quickly overwhelming the capacity of our hospital system. And one of the reasons for the public shutdown is because if we continued rate of transmission at the rate it was early in March, middle March, and even early April, we would have seen medicine being provided in tents, in fields, in convention centers. And that is what we've seen in Louisiana, this we've seen in New York, this we've seen across Italy and across the world. The extraordinary requests on people to stop meeting in houses of worship, to stop business transactions. The cost, whether it's worth it or not, is a value judgment. But the reason for it was the fact that even with the hard lockdown that we saw, that had amazing reductions in the total rate of transmission. It was incredibly effective in New Mexico. We came close to overwhelming the hospital systems. And in fact, if we hadn't pulled in, we had planned on covering the ICUs just with Albuquerque. If we hadn't pulled in Santa Fe and even Eastern in Roswell and started to talk about sending Blackhawks to Las Cruces, if we hadn't started to manage the entire state as one resource, we couldn't have kept up with even Gallup and Farmington's demand over the last 4 to 6 weeks. So with that, I want to turn it over to Cole. Cole is going to tell us a little more just about the science of the disease, the probability of a vaccine, the probability of a treatment, just in layman's terms a little bit. Cole is an undergraduate, so he has a Bachelor of Arts in epidemiology or in human biology from Stanford. But because of his concentration in virology and his relationships with his professors, he was actually able to consult with people like Governor Gavin Newsom on a 3-person team there. He was able to consult with Presbyterian and the Los Alamos National Lab on the New Mexico model. He is very well informed on this, doesn't hold a PhD or a doctorate, but I'm very, very pleased and proud to have him kind of share some knowledge with us. Go ahead, Cole.
Thank you so much for that introduction. If you could make me a presenter real quick so I could share my slides that I've prepared on this. And I'll talk for briefly while you're doing that on what I'm going to be presenting. Obviously, I can't go through every treatment that is under development or everything that we're doing in supportive care or everything about this disease. So I'm pulling out a little bit of what's going on in the medical community right now regarding COVID to kind of show some of the general trends regarding treatment and what we can expect in the future and how it relates to our overall efforts to try and mitigate against this disease. So everything I'm going to be presenting today is going to be based off of readily available research and mostly review papers that have been published by scientists in this field. You can access anything that I'm saying through the links that I'm going to be posting throughout this presentation. So first off,
Cole, can I just share one thing? As Cole presents, if you have any questions about my presentation or as Cole presents about his presentation, there is a chat box and there's a red arrow in the upper right-hand corner of most of your screens or a chat button, or a questions button, I'm sorry. You can enter questions directly in that question button. Only the moderators will see them and we'll answer them as we go through the presentation. Sorry, go ahead, Cole.
Okay, thank you very much for that. And I definitely am looking forward to the questions that come through the software that we've got set up here. So first off, before I get into treatments, I just want to run down really quickly what we're trying to prevent when we're talking about treatments that go beyond supportive care. There are 2 main ways that people who have COVID-19 are at risk of death. Those 2 main syndromes are acute respiratory distress syndrome, or something that looks a lot like it, that's ARDS. That's when the lungs begin to fill with fluid, and so it's almost as if people are drowning actually in their own lungs. This is what people go on to ventilators for. This is the syndrome that's killing a lot of people with COVID-19. And then something that's gotten a little less play in the media, but is also a big thing that we're thinking about in treating COVID-19 is an organ response, a mass systemic organ failure that comes as a result of COVID-19. So we've talked a little bit about problems with the lungs, but what we're also seeing in patients with COVID-19 is we're seeing liver failure, kidney failure, damage to the bowels, and especially a high risk of cardiovascular failure. This is why having prior heart conditions is such a major comorbidity for COVID-19 infection. It makes it much more likely that you will die from COVID-19 if you become infected with it. So when we're looking at treatments, we're looking at things that are going to be able to help patients with ARDS survive, help prevent the systemic inflammation that is leading to the shutdown of these organ systems. And also we're looking at therapies that will directly interrupt viral replication and therapies that will better mobilize the immune system. So the treatment process in the United States is based on a series of phases over which the FDA is going to oversee clinical trials. Phase 1 is mostly done for safety. It is a few dozen people, patients, and that lasts for a couple weeks. Then a treatment will move into phase 2, in which it's tested for safety and efficacy, whether the drug actually works. That takes about months. If it works there, drugs go into a phase 3 process that can last years and years. And that's where a lot of people take the medication and you really are drilling down to see if the medication helps people improve their outcomes. And then in phase 4, we put a drug onto the market and we monitor it afterwards to see if there are some large population-wide effects that might result from the medication. So right now, there are over 1,000 drug trials that are registered internationally to help fight COVID-19. There's a really cool tool that I've been using, and I think you guys could use too. I don't know if is it coming up on my screen right now, or do I need to change my sharing options?
Yes, it's there, Cole.
It's there?
Yes, it's there.
Okay, so let me get to this. Oh, now I seem to have lost it. pardon me. Okay, so this is our COVID trials. You see the COVID trials page right now?
Yes, we do.
This is a listing of every registered trial internationally right now that's working on trying to cure COVID. Obviously, we don't have enough time to go over each and every one of these, but this is a good resource to see what global progress is on working for treatments for COVID. And I think it's something that everybody could do well to go over a little bit in their own time. Now I'm going to go back to the slides. And my slides are showing, yes?
They are, and for the audience, Cole's PowerPoint presentation is saved as a PDF under handouts. You can download it from the red arrow section of your control panel, and the links are live. So all of the dashboards he'll show you are live, and you can take this for review afterward.
Thank you very much. So the FDA is monitoring actively about 144 of these therapeutic trials. These trials are working towards getting drugs onto the market, and they're in various stages of development. There are all sorts of types of therapies that are being tested. There are antiviral therapies. Those are working directly to inhibit the virus's replication on a molecular level. There are supportive therapies. That's stuff like ventilators that will keep patients alive longer so their bodies can fight the virus or may reduce some of the symptoms. There's blood plasma, which basically blood from previously infected patients can elicit immune responses, strong immune responses in people who are currently fighting COVID-19 and can actually help them survive longer. And so that's a therapy that we're developing and actually putting into practice across the country right now. There are some therapies that are being tested from traditional Chinese medicine, which may seem odd until you realize that actually one of our most powerful anti-malarial drugs came from Chinese medicine. So it is a field that people are looking into to try to get some purchase on fighting this disease. And then there's a whole bunch of therapies that are being tried that seem to show some early success either in laboratories or in a few patients in China or in other places across the world. And those therapies, we don't necessarily understand the mechanism of why they work, but we're also trying to test those out and see if they're efficacious as well. So right now, there are only 2 drugs that have achieved what is called an emergency use authorization. So the FDA is allowing both of these drugs to be used in very critical COVID-19 cases because they have been shown to have efficacy in earlier stages of clinical trials, but are not yet ready to go onto market. And this is how you're going to see most new treatments for COVID-19 begin to get to patients, is through these emergency use authorizations. An important note is we don't actually know whether either of these drugs works. There is some evidence that they may help COVID-19 patients, but neither of these drugs have definitive proof behind them. And since these are the 2 big drugs that are being talked about in the media now, and rightfully so, they're the 2 most promising that are, being used by patients right now. I'm going to share a little bit more about each of them. This first drug is called hydroxychloroquine. It was originally an anti-malarial drug, quite an effective anti-malarial drug. And it doesn't actually have a very well-defined mechanism to fight COVID-19. It may have some anti-inflammatory effects, which will help with the organ system damage. It actually has antiviral effects in vitro. That means in lab dishes, it seems to inhibit viral replication. The scientists aren't quite sure why that is. And it's had really mixed results in completed clinical trials. Some of them have not shown much of an improvement in patients. Some of them have shown an improvement. So it's not definitively helping patients who have COVID-19. And I just want you guys to keep in mind that just because something kills viruses in a petri dish does not mean it will also kill viruses in a human or help a human survive from a viral infection. Moving on from hydroxychloroquine, we also have remdesivir. Remdesivir is an antiviral drug that was first trialed to actually try to help with the Ebola epidemic back in 2014. Now, remdesivir works by inhibiting the viral polymerase. That is the copier that helps a virus actually copy its RNA over and over. So this drug kind of jams the copier. And some clinical trials have shown that it has a moderate impact on recovery time and risk of death. Now, something I want to say about both of these drugs, even though they're being used, they may both work. Both of them may be completely ineffective. We do not have enough evidence now to know whether either of these drugs works. And the best case for these drugs is not a cure for COVID-19. The best we can hope for remdesivir or hydroxychloroquine is that they are making the disease a little bit less severe in patients, which will be a great help on a population level, but will not remove the threat of this virus. And I also want to really stress that you will only ever see these drugs if you are in really dire conditions. These are being prescribed to patients on ventilators. They're not being prescribed to people that are testing positive in an ER or who are just requiring, basic supportive care. Please do not try to self-medicate with any of these drugs. There have been cases of people trying to medicate with what they thought was hydroxychloroquine and having some pretty severe reactions based on that. So please do not take drugs that you have not been prescribed by a licensed physician. I wanted to talk a little bit now about the vaccine process. In general, there are more treatments that are further along in development than the vaccine. So I showed you that model of phase 1, 2, 3, 4 development. Currently, no vaccine candidates have made it past the equivalent of a phase 2 trial. Vaccines can take a little bit longer to validate for safety because unlike treatments, you'll be giving vaccines to healthy people. And so the standard of safety is very, very high in vaccines. Vaccines also need to be manufactured in a bit of a different way than treatments, which I'm not going to go into in too much detail, but just know that it's rather complicated, and it means that they're a little bit harder to scale up than just your run-of-the-mill remdesivir or your hydroxychloroquines. So let's talk a little bit about how vaccines are being developed right now. There are over 100 different projects to develop vaccines globally, and they are using a variety of different technologies. You can find a more complete background on this that's pretty up to date on Healthline, and I've got that link up in the top right corner of the screen. There are currently 8 candidate vaccines that are in clinical trials right now. I just wanted to go over a few examples of some of those vaccines to give you a sense on what is being tried to vaccinate against COVID to hopefully make people immune to the virus. The first of these is from a company called Moderna. It is in its phase 2 trial. Remember, that is the first stage in testing for safety and efficacy in humans. Basically, it takes what is called mRNA. That is the sequence that tells a cell how to make a virus so that the cell will then, make, hundreds and hundreds of viruses and infect a bunch of other cells. It takes that message and it slices it apart into just these tiny pieces of instructions. We just take a small bit of that message that is too small to ever cause infection, but is large enough to produce something the immune system can react against. And so what you would do in this vaccine is you would inject a lot of these tiny pieces of the same region of the virus that can't cause infection but does elicit an immune response. Your cells will make a lot of that protein, and then your immune system will become good at recognizing that protein and will make you immune to the virus. Another type of vaccine technology that's currently being worked on is what is called a DNA vaccine. DNA vaccines work in a very similar way, just the delivery method's a little bit different. Instead of injecting mRNA, instead we are injecting viral DNA that'll code for the viral protein. Once again, there is no risk of this ever becoming the virus. We are not injecting a whole virus in this vaccine. This is just a small, small piece of protein instructions that your cells will make and elicit an immune response. And then we have a University of Queensland study that is preclinical right now, but I wanted to show it because this is more of the traditional way we think about making a vaccine. And this is currently being investigated as well for COVID-19. So here we are taking a cell culture, in this case, dog kidney cells, and we are growing up virus in those cell cultures. And then we are inactivating the virus, basically making it impossible for all the virus particles to infect the human. And then that becomes the vaccine, those dead virus particles, if you will. And this is the vaccine type that we use for rotavirus. One of the polio vaccines works like this. Smallpox works like this. Several hepatitis vaccines work like this. Rubella, chickenpox. You get the idea. This is a very, very common way of making a vaccine. This is actually how we make the flu vaccine every year. So what I wanted to show you here is that there are a lot of different methods that people are attempting to use in order to get to a vaccine the quickest. But if we look back at this chart right here, you can see why it is unlikely that we will get a vaccine before the year is out. This process of developing a vaccine usually takes about a decade, a little bit less than a decade. When it comes to the flu vaccine, we can make new vaccine every year because we are switching out some small components in order to change it every year. But this is an entirely new vaccine, and so in most cases, we are doing complete work to build a vaccine from the ground up and working as fast as possible. And that is still only going to allow us to develop a vaccine at fastest in about a year, or maybe 18 months, in that sort of range. But even that is if everything goes really well. And that's why there are so many different candidate studies right now, is because if you have 100 vaccine candidate studies, it increases the chance that one of them is going to go really well and be able to skyrocket and be produced in about 12 to 18 months. What I don't have here on the graph is once we have a really effective vaccine, we're also going to have difficulty in scaling up manufacturing for that vaccine. And that's something to keep in mind too. Just because the FDA has approved a vaccine does not mean there's going to be enough of it to vaccinate everyone. And that's going to take time as well. So it is unlikely that in the short term, we are going to be able to rely on a vaccine to free us from other types of health restrictions and health protection orders. We are going to have to deal with this virus with other methods until we get to a vaccine. And that's just very important to keep in mind. So that's a little bit about what that timeline is. Another question that I thought people might have is whether we will need to be getting this new theoretical vaccine seasonally, like the influenza vaccine. I wanted to say that there are some things about influenza that make it unlikely that we will be vaccinating against COVID-19 in the same way. To demonstrate this, I wanted to show you what the two genomes of these viruses look like. On the left, we have the SARS genome. It's very close to COVID-19. As you can see, it is one long line. It is one segment. On the right, you have Orthomyxoviridae, which is which is the family that influenza is in. You can see that it has 8 segments. Influenza can actually mix and match these segments when different influenza viruses infect the same cell. And that is one of the things that allows influenza viruses to mutate so quickly. Influenza viruses also use a different polymerase. Remember the copier that we were talking about earlier? And that polymerase is more prone to making errors. So for those reasons, influenza is mutating at a much, much faster rate than COVID-19. And that is what allows influenza to basically beat our vaccine every year. And so we have to keep updating our vaccine for influenza. It is very unlikely we will have to do something similar for COVID-19. It is very likely that once we develop a vaccine, that will be the vaccine that we can use and give us immunity for the rest of the course of this epidemic. You probably will not need to receive multiple vaccines. Another question that a lot of people are asking right now is, if a vaccine becomes available, is it going to work? Is it going to work well? And of course, I can't answer those questions because there isn't a vaccine available yet, so I can't evaluate how effective it is. But I will say that even if the vaccine works, only 40% of the time, it only gives you immunity 40% of the time or 30% of the time, that would greatly help us in responding to this virus with public health efforts, because it would reduce the number of people that ultimately need to become infected before we achieve what is called herd immunity. So the flu vaccine is a great example of this concept. The flu vaccine has its years where it is, 70% effective, 60% effective, but most of the time it is lower. It is in the 50% or 40% effective range. And so when that flu vaccine goes out, it is not useless. It saves many, many lives. And we can actually see differences between communities that have high rates of flu vaccination and low rates of flu vaccination, even when the flu vaccine is not, 80, 70% effective. And that is what I had to present on, generally the vaccine and the treatment. What we're looking at here then, just to review, is we have some very promising candidates for treatments that are being used now. It's likely in the next 6 months or so, we will have treatments that make this disease a little bit more manageable. We should not expect a cure. And the vaccine will likely take quite a long time to develop, although we are working blazing fast in terms of what we have done traditionally with vaccine development. And I think that is very heartening that we are probably going to have a vaccine in the long run, but we need to get there in the short run. And that is all I had to present with you, to you guys on the science of the various treatments and preventions we're working on. I hope that was were looking for, and I can answer some questions on that as well if people are curious.
Cole, thank you for that. We did have a few people send in questions that they were having trouble seeing the slides. So on the control panel box, which is the red arrow, in most screens, it's your upper right-hand corner, there is a section called Handouts, and that is where you can download the complete slides with links for Cole's presentation. Also, on that same control panel box where the red arrow is, there is a section called Questions, and that is where you can enter questions and send them in. We can answer some of them privately. We'll answer some of them publicly. We have no questions submitted right now other than some technical difficulties on viewing the slides. Cole, we'll wait for some additional questions. So I'd like to what Cole shared is essentially is that a vaccine is probable, but it's not timely. And so what the medical advisory team has been looking at is it is not realistic to continue to shelter in place. And so what has been trying to get in place are what are the safe public health practices that can be put in place so we can safely reopen, and what are the gating criteria at which we can relax or tighten those restrictions so we can safely reopen without a huge sacrifice from vulnerable sections of our population. With that, are a couple specific things I want to mention in the governor's orders. So the governor's orders essentially began yesterday, and for places of worship, she'd originally wanted for the places of worship to be limited to 10% of their fire marshal license capacity. That was then the next day updated to 25% because there were a lot of concerns that treating retail at 25% and houses of worship at 10% was discriminatory. I will tell you the reason that the houses of worship were wanted to be provided at a lower occupancy was based on a study that's been replicated, but the one that I have referenced to is out of Seattle. One of the most dangerous group activities that can happen is group singing. And in the process of singing, you create aerosolization. So COVID-19 is generally a droplet precautions disease, which means it's generally expelled droplets from your mouth when you say t and duh and hard consonants, or when you sneeze, or when you say k. And so those droplets leave your mouth, and either they're inhaled by someone nearby, or they land on a surface where they can live for hours to days. In that case, a mask, a cloth mask, although it is not tightly bound enough to stop the actual virus protocol if it were virus particle, if it were aerosolized, a cloth mask is highly effective at stopping droplet particles from going into the air where they're going to be inhaled by other people, or from landing on surfaces where they're going to be live for hours to days. So the purpose of a cloth mask in public is not to stop you from inhaling an aerosolized virus particle. The virus particle will come in around your mask, or will come in even through the weave of your mask if it has been aerosolized. But it will stop you from inhaling droplets, or from touching droplets on a surface that may not have been contaminated because someone wasn't spewing droplets, or from touching your face, which is the number one way that it's a nosocomial infection, where it goes from your hand to your mouth, hand to your nose, hand to your eyes. So that is the reason for cloth masking in public. It is not some false belief or superstition that somehow the virus can't get through a cloth weave. Of course, when we're doing aerosolizing procedures, like when we do the swab for the test, or when we do a nebulizer, or when we do a CPAP, we use an N95 surgical mask, not a cloth mask. In healthcare settings, we use a surgical or procedural mask, not a cloth mask. But a cloth mask is effective in public gatherings. So the governor's order, one of the most important things it does is requires in public that you wear a cloth mask, and that's the reason why. Another thing that's important about the governor's order is that I've lost my train of thought. Now it's going to be lost forever. Another thing that's important about the governor's order is that the stay-home order for vulnerable populations remains in place. And the state defines vulnerable populations as those over the age of 65, those with underlying chronic conditions like emphysema, pneumonia, COPD, diabetes, and these are all associated with higher susceptibility and higher complication rates from the COVID virus. And so the governor's construct is basically that we're going to move from a total shutdown to safe for some, which is where we've moved to now, which means we're going to allow partial movement, reopening in the economy with a lot of COVID-safe practices in place, frequent wipe downs, limitations on social distancing and on total occupancy, coverings of face to stop droplets, things of that, and we're going to ask vulnerable populations to stay home. Then we'll move into safe for most, and then finally safe for all. And based on the gating criteria, which include the availability of ICU beds across the 7 hub hospital systems, the availability of personal protective equipment for healthcare workers across the system, the prevalence and transmission rate of the disease in our public, those are some of the most important gating criteria that will exist to see whether we can advance from safe for some to safe to most, which is more relaxed, or whether we will revert from safe to most to safe back to safe to some, more tightened, is based on the data that's coming forward. So that's how the governor's order works. It is available on that cv.nmdoh.gov. And so that Department of Health website has a lot of great information. It is a very transparent place. You can read the slideshows from every one of the governor's press conferences. You can read the public health orders. You can read the CDC guidance for houses of worship and regathering. And so that is what the elders tasked Chris Clifford in putting a task force together to do, is to use all of those available resources to put together a plan for reopening AnchorPoint Church that was safe and compliant and responsible. So that will turn it over to Chris.
Well, thanks, Clay. First, I want to let Dan kind of explain what our process started on reopening. We'd originally planned on starting this out on June 7th, I believe is what it was, but now we've moved it actually up. So I'll let Dan kind of flow into that and kind of explain when we're meeting and why.
Yeah, and that's been quite the process trying to figure out. It's been wonderful being, we're not technically part, I guess, of E3 yet, but we've been getting tons of good information from different evangelical free churches around the nation, what it's like to reopen in different states that are in different processes ahead or behind us, that also have medical people in, how to do it safely. And so we took that information and tried to look forward to say, okay, if we could open at X%, what would it look like? And what would the next stage look like? Because we had to be, we were busy back in March saying, what do we need to order? What do we need to get our hands on? Because things are becoming hard to get. And I mean, you can't open a church without toilet paper either. And make sure we were kind of ahead of the curve on everything. So some of the things we learned from that is we need a 2-week supply of sanitizer and being able to keep the church good. And so do our cleaners. So we need a 2-week supply of what we need to do between services and then the cleaners before services start, so that we don't open for 2 weeks and then close for 2 weeks and then have to reopen again. Things like keeping the doors propped open all the time. What would the numbers be for each service? Do we start first with 3 services? So that was our original look. And that seemed to be the right guess until we went from 10% to 25 here recently. But even at 25, we want to be sure as a church that we're opening safely. So we strongly believe as pastors and elders that we need to obey the authorities over us. We get that from Romans 13. And, they obeyed the authorities over them when they had to worship in homes with Nero as the emperor. It is just not an option for us. We're going to obey the laws until the laws tell us to sin, and then we're going to disobey them. But the law is not telling us to sin. So for me as a pastor, this is not a question of do mass work or do mass not. It's a question of what is a government order, and is it something that asks me to sin? If it's not, then I need to keep to it. So we didn't meet for a while. We could still meet in homes. We could still meet on Zoom. Now we're going to be meeting another way. But even though she said 25%, then the question comes back to us, can we meet with 25% safely? Because just because she said we can doesn't mean we can do it safely. And so one of the suggestions from the evangelical free churches is that we have a health advisory team made up of a mix of people, but a number that are clinical, to make sure that however we open is also safe. So we're already, and this just impacts every area. So children's is currently on hold. We're going to have to open up the annex so we can put some people in the annex as well as the sanctuary to keep everybody separated enough. We're looking at the possibility of tables so that people that live together, family units, can sit closer together and we can separate other people more. We're removing all the Bibles and the pens and just all the stuff that's in there, all the food and all the coffee, and asking what you take in, you also take out. And we may have a stack of Bibles at the back, but if you take one, you take it home with you. It doesn't stay there for someone else to open. And so those are things we're currently doing and have been doing. We've ordered hand sanitizers that are touch-free, but they won't be until July 1st. So we have other hand sanitizers and we'll have instructions by them. We've been trying to really think and get ahead on all this stuff. There won't be any bulletins for a while. But then there were more major questions like the bathroom situation. Do we have them? Do we not? If so, how? The governor has asked for face masks. And again, for me as a pastor, there are speed limit laws that I really, really don't like. They bug me worse than a face mask law. But good grief, we keep the speed limit law not just for us, but for others. It may be your right to go out and drink, but it's not your right to drive drunk. If they believe it keeps people safer wearing face masks, and we want to do it, and we really want our church to be safer than an average place that you would go. We care about our people. We care about our people that are in high risk. And so anyway, using the information we got from Evangelical Free as well as others, I thought, I've got to have a medical advisory team. And that way, if you don't like anything that we're doing, then you can get upset at Chris, and I'm good to go. So, Chris, what are some things, I guess, that have, I'm just kidding. What are some things that have come across that decisions you've had to make, and where are we going with them?
Okay. Well, first of all, let me give a little background of what I do. I actually have been in the medical laboratory field for over 30 years, and I currently work for Tricor Reference Laboratories and their leadership group. And I oversee 11 different collection sites, one of which is our major sick clinic where we're collecting the COVID swabs and blood work on those sick patients as we speak. Our laboratory started out in first part of March only doing 500 of the tests per month, and we just topped our 6,000 tests per day this past week. Wow. So we see a lot of this going on, and so Dan asked me if I would kind of oversee a group of other medical professionals, which Clay helps me with, my wife, Jolynn, some others, and I've asked their input, and it's been great so far. And the one thing that we really wanted to do is try to make this as simple as possible, because if you try to understand what Cole was presenting, and there will be a test later on, it's a very complex situation that they're going through to try to get this treated and working for us. But we need to try to make this as simple as possible and as safe as possible for our church family. So it is going to look a little different coming into church on a Sunday morning and on how we're going to do this. For example, you're going to come into the parking lot and you've got the choice right there of just staying in your car and tuning in to the FM station 91.5 and listening to the broadcast. 101, is it 101? 101.5.
Yeah.
Okay, 101.5, sorry. And listening to the broadcast, and that's really recommended for somebody that might in that high risk situation. If you really are just have to get out, maybe that's where you stay. Now, if you choose to get out of the car, there's going to be signage as you walk up the walk with the little sandwich boards that we have that kind of tell you, welcome back to church, but there's some new protocols that are in place. First of all, a mask is required if you're going to step into the building or be there at service. And if you don't have one, we will provide you a mask. Sandra Atwood has ordered masks for everybody. I just talked to her today. The other thing is when you walk up to the door, there will be greeters that will be counting who's going in and out of the building so we can stay at that 25% capacity in the worship building, which is around 90 to 98 people. That's including the staff that's there. The annex is what, 50, Dan? In
Yeah.
that area. And then our overflow area will be on the lawn, weather permitting, you know, and we'll have easy ups there that people can sit there and listen to the service. We'll not even have the TV out so they can see the service. So there's lots of opportunities and options. And even if you choose not to come to the church, you still have the opportunity to watch it live via online that we've been doing it so far. One of the things that when you step in there is we're going to take a temperature with a touch-free thermometer, and they're simple to use. Like, I've got my victim here, my guinea pig, which is my wife, and that's it. She's 97.2. She's acceptable. But what we're not going to be able to do is if somebody shows up with a temperature above 100 degrees Fahrenheit, we'll test it again really quick. But if you're consistent at two times up there above 100, we're going to ask you to either listen to it in the car or go home and watch it online. And it's just a safety precaution that we have. We're going to have the capacity in the worship building of 25% of the capacity, and at the annex, like I said, there'll be some tables for families, and there'll be some chairs for individuals that want to sit in there. There'll be a few little screening questions as we take your temperature, like, you know, have you had any health symptoms? You probably, if you've gone to any medical facility, including a Presbyterian Lovelace or UNMH, you have been asked these questions and your temperature's been taken, and that's just part of it. Now we also requiring a mask to be worn. As you go in, if you're going to sit down, you're going to be at one of the tables. Everything before you walk in will be cleaned and disinfected and ready to go by the team that's taking care of it. And then once services are over and you leave, that will be disinfected in between services to try to keep it as safe as possible. We're going to limit the amount of people that can go into the restrooms, 1 to 2. And if you have to accompany a child to go in there, that's fine. And there's going to be instructions on, we don't have the aspect of hands-free sinks. We have handles. So we're going to have towels there that you can use to turn the water off and on. And the same way with the hand disinfectants. It's just because right now with the situation that we have to make good with what we have. So we have to try to be as safe as possible. But one of the things that we really need you to do is if you're in one of those categories and there's enough information out there that you can go to, that if you are in that high-risk category, your best bet right now is to stay home and listen to the services in your car or watch it online. There'll be no children's church, no hospitality, anything like that. But, we definitely have to have restroom services. So we have to be able to clean those things fairly regularly. And fortunately, we have a great hospitality team, security team, and a welcoming committee to do this. In the church, there'll be directions that you can go one way in and one way out. So you're not going out the same way somebody's coming in. And those exits and entrances will be monitored by our security team, and they'll help assist in what that is. I'm meeting with the security team on Saturday morning, and we're going to kind of discuss how that flow will be. They'll have counters so that we make sure that we're within the normal range that's acceptable for the 25%, and that it's flexible, that we can do that and do it as easily as possible. And the best thing is, and we wear a mask, do our social distancing, we do good hygiene. Just doing one thing is not 100%. Not 100% on the mask doesn't prevent or keep you from catching it or spreading it. It reduces it. Same with the distancing, same with the hand washing. It's a reduction of risk, and that's what we're looking for. And that's why we're asking everybody, please comply with it. And if you can't comply with it, then we need you to assess on how you want to worship. And so we welcome everybody back. Today we had the graduation walk, and I think we had 38 cars in the parking lot at one time. And it was fantastic, and it was good to see everybody. And it was good to see everybody in a mask, pretty much. And everybody really was practicing that social distancing for the most part. But it is a new system, new way of how we look at the norm for right now. So we have to be compliant. We have to just be gracious and think. The worst thing I would hate to do is I would be asymptomatic, and I think I'm not going to catch it. I don't need to wear a mask. and I'm carrying it and not showing any symptoms, and I spread it to somebody that has an immunocompromised system, and it catches to them, and it really does some detriment. I don't know if I could hardly live with myself if I gave it to somebody that I loved at the church. So if there's any questions, you can ask, and we'll try to keep it as simple as possible. Because that's how we want it. We want you there to be able to worship God, not be worried about everything else.
So we're right at the 1 hour mark, and we have this webinar open for another hour. Dan, I've got about 7 questions queued up that I'll start to farm out. But if there are going to be people jumping out before we jump into the Q&A, do you have any closing comments before we jump into Q&A?
Yeah, just a couple. One, just to thank you for you guys and doing this. Thank you for our elders and staff in all the changes we've had. It was like 10 weeks ago we ordered a transmitter. It was on an 8-week delay because all the churches and whatever, but it's come in. We use it for the graduation, and I'm excited about that. Just a couple other things. One is, I just think when we come to church, we've got to remember our vision is to worship God. That has to be paramount. Our vision is to worship. It's not, it is going to be different, and it's going to be difficult to go, read the signs and do whatever. But our vision's about worshiping God. It's not about having our way. And so the whole idea of putting the goals and interests of others above my own is so important. And even the goals and interests of the security team that may seem to be cracking down too hard, or the health team who seems to be requiring too much. I'm going to put their goals and interests in others above mine, because our final hard attitude says to obey the leaders over you within scriptural limits, and make their life a joy for them. And we want you guys' life to be a joy, and our elders. And so I hope we can do that. That say, okay, wait a minute, why am I here again? I'm here to worship, and I'm going to do that in the safest way possible for others. And then I think it can be a really cool time coming together. And we've learned a lot after the graduation today. I'm hoping like October, whenever the weather's good. I think it'd be so cool to do an outside service over the radio. And man, with the speakers, no matter where you were, you could hear everything perfect. Have the band outside. And then instead of the grads walking through, we have a bunch of food walking. Anyway, we could just have a good time out there. Okay, questions.
Okay, I'm going to read these in the order they were submitted. And so this question was submitted about 20 minutes ago. A report today said that Canada is testing a vaccine. What kind of vaccine are they testing? And Cole, maybe you could just tell us what that resource was. Let's not go into all of the 1,000 different tests and treatments that are in development. But where can people research that reliably? You're on mute, Cole.
Sorry, I couldn't find the unmute button for a second. I'm not specifically familiar with that Canadian vaccine trial. I know being trialed in people is phase 1 testing. And so as far as I know, there has not been a vaccine to move beyond phase 2 testing where they're testing efficacy. So I don't know if that changes anything in the timeline. I'd have to look up the specific trial that you're mentioning in Canada. The resources that I think are really useful, they're the link I posted, and maybe I'll put it. I can't put things in the chat right now for everyone, so perhaps
I can type it in for you on the question answer grid.
But the handout that I have put up on the handout section of this meeting has a whole bunch of links that will really help you in looking at trials and treatments. So there's that COVID trials dashboard that you can go to via the link in the handout. That dashboard has almost every single drug trial, in the world right now, and will bring you to sites where you can look at what people are doing. Not all that information is going to be completely up to date because the people doing these trials are not constantly at their computers reporting what's happening in the trial. They'll report what happens in each stage of the trial when they finish the trial. And there's actually a bunch of legitimate scientific reasons for doing that I'm not going to get into right now, but it prevents things like conflict of interest and keeps people unbiased while they're doing their trials and things like that. But that's a really good resource. If you want something a little bit simpler, there is a great article from Healthline that I put up that is reliable, links to a bunch of different sources, and goes through a bunch of the more prominent treatments that are being tested right now and the more prominent vaccines. But I do want to urge at the very end of this, though, that nothing is currently available and licensed for general use. There is nothing that you're going to see without the prescription of a doctor. And there are physicians that are prescribing things that have not been shown to work in clinical trials. And some of those are based on reasonable, educated guesses. And if you were to catch COVID and your physician suggested, well, let's try this long shot, your physician went to medical school to do things like that. And so that may also be something. I'm not going to say that listening to your physician is ever a bad idea. So I will say at the bottom line, default to your licensed physician, default to health professionals. They really do spend their entire lives working in this stuff. And so I think we should all give them as much trust as we can.
I'll chime in. I'll chime in with Cole is really look at his links first and what's going on there, because you can go down a lot of different rabbit holes listening to certain things that are on the news, because the news is really wanting to find a quick answer, and there really is not a quick answer at this point. The research that's happening with all the things that the links that Cole is mentioning, those are the reliable sources. So we want to just make sure, yes, there are these things out there that they're saying, yeah, it's all in approval and stuff like that. Really do your investigation on reliable web pages like what he's linked you to before you start just asking your doctor.
For the audience, I am typing these answers into the question panel. So if you expand the question panel, you'll be able to see which panelist answered and what the answer is, and so it'll be recorded there. And then the handout is also there for download. Go ahead, Cole.
The last thing I wanted to relay, I just wanted to signal boost Chris a little bit. There are some treatments out there on the internet that will kill you right now. So it is actually a matter of life and death that you listen to reliable sources here. There were one or two treatments that I was looking at a while ago that were actually putting people into the hospital. And I won't get into any of those because I don't think we need to shed any more light on hoaxes. But there are snake oil salesmen out there, and they do not care for your safety. So I think that is a really important thing to signal boost.
Well said.
Question number 2 says, Clay, I'm wondering if our goal is still to flatten the curve. Are we hoping that flattening the curve will also reduce the area under the curve or lower the overall number of cases? So the answer is yes, and kind of. What we're trying to do right now is to dance with the virus, okay? And there's an article you can search called The Hammer and the Dance that explains this very well. The phase we just left for the last 7 to 8 weeks was the hammer. We shut everything down to get the rate of transmission away from catastrophic overwhelming of healthcare resources where we could not meet the needs of treating people, to a controllable level where we had the resources that if people were infected, we could at least treat them, and we could get testing up to a level that we could begin to do surveillance in a much more effective way, and we could begin to do much more nuanced closures of parts of the economy, parts of the population, and not have to use a hammer again. So the hammer and the dance. So our goal now is to wait for a vaccine and a more effective treatment. And while we do that, it's to manage the infection rate in the population to something that is manageable within the resources of the healthcare system. So that's it. It's trying to get testing up, wait for treatment, wait for a vaccine, and manage the transmission rate to something that the healthcare system can handle. Currently, the estimate from the medical advisory team is if we can keep the rate of transmission down to 1.15 or below, which means every person who gets it will only infect 1.15 more, that slow rate of growth will get us towards herd immunity without overwhelming the health system, and we can provide effective treatments for many. So that's the goal of treatment today. Chris, anything you would add, or Cole, what you would add to that?
I not specifically that. I actually had a follow-up to Patrick and Patricia's question on the specific vaccine in Canada.
Okay, you want to go ahead and just type that in there? Are you able to or no?
Actually, you know what, I can. Thank you.
Okay, thanks, Cole. Okay, and then there's another question coming for you, Cole, while you're trying to type, so I'm going to make you pause for a second. Cole, great presentation. Thank you. I'm wondering how the vaccine might be produced in large quantities once we have the approved vaccine. Will the company that develops the winning vaccine share that info with other production facilities? How does this typically happen with the flu vaccine each year? Great question.
Yeah, so fantastic. So the way that the flu vaccine is currently developed is the federal government contracts with a bunch of manufacturers to work on developing different strains and things like that, right? To try to better match what we're seeing with disease surveillance in the CDC. And then that formula for making the new vaccine gets spread among all those manufacturers, and they grow up the virus in chicken eggs. And there's been some experiment in recent years in doing it in cell culture instead. That was to try to get around, the thought that there may be egg allergies to the vaccine, and that didn't really pan out. That's a tangent. Anyway, the flu vaccine is very special. It's made up in these chicken eggs. We don't actually make a ton of vaccines that way. Most vaccines are made either in culture, or you grow up the virus on its own, or you grow up the viral components using bacteria. There really is a myriad of different ways that these viruses are grown, and it really just depends on the vaccine. So when I talked about the mRNA and the DNA vaccines, it's very likely that those would be grown up in what are called bioreactors. So they'd get a bunch of bacteria together to, produce more and more of this plasmid or this DNA construct that would serve as the vaccine, and they'd purify that down. But I think the question was really more about the regulatory thing that would happen here. Would other companies be able to copy this winning vaccine? And there's a little bit of future sight going on there. Nobody has said, oh, if somebody develops a vaccine, we're going to allow everybody to copy it regardless of patent. But that's going to happen. I don't see a reality in which this vaccine doesn't get produced by a bunch of different manufacturers, because one manufacturer will not be able to anywhere close to approach the need of the population. And in fact, I was listening to a research panel the other day that was talking about the fact that multiple vaccines even are going to be needed to meet the global demand for COVID-19 vaccines, because one production method is going to overwhelm that sector of vaccine production for that cycle. And so we will eventually need multiple different types of vaccines to produce in multiple different ways to use all of our built-in and expandable vaccine manufacturing capacity in order to serve everybody. So I hope that got to the answer. I know that was a little bit meandering, but
Yeah,
did I answer the crux of the question?
Yeah, that was good. There was probably an economic capitalism angle to that would probably gets to how do you stop people from acting in a monopolistic way to maximize profits for shareholders. And this is a case where governments will use public health orders in order to take over manufacturing if needed. And so there will be ample reward for those who come up with the effective vaccine. That's what you see in the federal investment that's going in. But there will not be an ability to monopolistically quash that, would be my opinion. But let's go forward. Dan and Chris, what can we do as rank and file members to help out? What does the church need from us?
Well,
volunteers, they want to help.
Anybody that wants to, kind of, if they want to help kind of sanitize the areas in between services, they can help with that. If they find bulk areas of hand sanitizer, my sister-in-law just was at Target and got us a large thing of hand sanitizer. If you can come across that, making masks that people can use. But, as we kind of go into this, we're going to see where the needs are going to be in which areas. Do we need to have more people in between, kind of wiping down service places in the restroom as people go in and out, keeping count of the track of people coming in and out of each building. So I think once we get through the first couple of weeks of services, we'll know where the needs are. And if you're wanting to, please come see myself or Dan or Cole, Clay, or my wife, and say, hey, what can I do? We'll find something for you to do.
Yeah, there's I would also add to that, just in buying stuff, Lysol for the back of the chairs. Haven't been able to see that in forever and ever, in an aerosol kind of way. We are going to have a big cleaning day to get everything super clean, and then have the cleaners come over and sanitize, I think, even after that. And so that would be, I would email office@anchorpoint.life, and Diana is setting up that cleaning day so that we can get, especially the annex. We still have scaffolding up in the annex, and they've been painting in there, and we just got the storage room done, and there's a door going up. So this week there's tear down, and then the week after we're going to be doing lots of cleaning. We've got to stack chairs. So I would think just emailing office@anchorpoint.life or calling, and then she can funnel you to maybe Ronaldo for facilities. Sandra's doing a lot of the hospitality. So you could email outreach@anchorpoint.life directly for that. And I'm sure we can get you involved, but we're going to have to do kind of small groups at a time and get all that done. But thanks for the question.
And the other thing is yeah, and Cole, if you have any information on this, chime in. We were talking about possibly going into getting plastic chairs or metal chairs or something like that instead of having the fabric chairs that we currently have. But it seems like the harder surfaces is where the virus tends to dwell the longest. In that, in a fabric, it's not quite as bad. And Lysol sprays would be your best bet to just kind of do that. Otherwise, we have to saturate the fabrics. I don't know. That's one of those things that we've got to kind of prepare for.
I saw a really good study with seasonal coronaviruses and their survival on surfaces. Their survival on surfaces should be very similar to COVID-19, so I think the study could be interesting. But I don't think they looked at fabric. My intuition would be the less porous the surface, the easier it is to clean. But I have seen that metallic surfaces and plastic surfaces are also better for COVID-19 survival. So I think that it depends on how often you're cleaning and what goes along around that. I would worry about there being some viral survival and trapping in the fabrics, but any material is going to have problems with being a fomite.
Hey Cole, has anybody had the wisdom that I have to check how long does this stuff last outside, like on a playground? Because I'm thinking, okay, it lasts, I don't know what it is, 5 days, say, on plastic inside a lab at 68 degrees. But what's it like in an average 20-mile-an-hour windy day in New Mexico in 90 degrees? I'm just curious to know, can it die overnight in that or not? Is there a study on that?
Well, what's really difficult is the detection methods we have for viruses in the environment. So what you would want to do, and Chris would know a lot more about this because this is that RT-PCR that you guys are doing so much at Tricor, but what you would do in one of these experiments is you would just sample a bunch of areas and then run the RT-PCR to see if you get a positive result. But those tests are not necessarily meant to detect small quantities of virus in the environment. They're meant to detect virus in a human being, and you can have environmental tests, but even they aren't going to detect, just a little bit of virus. And so it's often hard to tell if what you're detecting is infectious or still viable in any way, even if you do detect something. And so the best examples of what you're talking about, the kind of trials that I think we have been able to do are hospital trials, where we can look at how far from a patient's isolation room you can detect, COVID-19 RNA. But it's still very difficult to extrapolate from that where the infection would actually be able to occur, right? And that's just, it's a limitation of what tools we have to work as scientists. It is not as simple as, taking a science magnifying glass and looking for the virus. It's excruciating work. And I think that's where some of the gap in information is. Another way that we can find out how far this virus will spread on like a windy day, for example, is we can look at events where we know where one person who had the virus was and where they traveled throughout the event, and you can see who got sick where at the event. The best place to do this is on airplanes, because everybody's got their seat. You can tell if someone didn't move past their seat that only people around them got sick, right? And that's actually where we get things like the 6-foot social distancing protocol. That's from looking at airlines and who got sick with one person on an airline having a disease, right? So, but we have to wait for experiments like that to happen. It's not very ethical at this point to put one person with COVID in a room with a bunch of healthy people and see who gets infected.
Oh God, no.
Well, that is way more basic than I thought it would have been.
Right, and then the other thing you got to look at is we worry about these fabrics and stuff, but it's still a nosocomial type thing. You could be on there with it and have your hands on the hard surfaces. If there's droplets and you catch it, the best thing, don't play with your face. Disinfect, wash, keep your mask on. If you do that and keep these things going, even if you become in contact with it, your likelihood to contract it is a whole lot less if you're using good hygiene.
You're not going to absorb it through your hands.
No.
All right. So the next question says, how far have we been relying on data modeling? These are never correct because they aren't supposed to be. Yet as state or from statements from the governor or Dr. Scrace have used these numbers as predictors in their messaging. Cole actually helped with the New Mexico model, but let me just share first of all models are wrong, some are useful. The New Mexico model was developed, it was based on a number of state models, the Washington model, the Penn model, a whole bunch of other models. Cole can tell more about that if you want, but it is a learning model. And so in consolidation with Los Alamos National Labs, the State of New Mexico Department of Health, UNM, and Presbyterian's Analytics Organization, they have direct feeds from the epidemiology department of the Department of Health and from New Mexico hospital utilization data and all of the major labs. And so it's got more information coming in than just about any model in the world, to be honest with you. And in that information, as more data builds, it learns better on its prediction and it self-corrects and adjusts. And it now is at a point that it makes different susceptibility and hospitalization predictions based on underlying ethnicities, county or region of residence, and social determinants. And so it is very, very accurate at this point for the next 14 to 21 days. What it is not accurate at is predicting the social response or the policy that's going to happen that will then change beyond that 21-day curve. Cole, anything you would succinctly change to that? Or
I just would drill down a little bit more and say, from a scientist's perspective, a model is a way of aggregating things we know about the world and then using that to make predictions. And we are not God. We are not omnipotent. And so any model that any person or any group of people, no matter how smart and how well informed they are, will always be wrong about something. But it is better than making predictions without a model, because what we'd basically be doing is making predictions with none of that data, with none of our view of the past. And I do believe that God gave scientists wisdom so that scientists can make models and can try to make predictions and try to help people with those predictions. And so I think that's something to keep in mind with models, is that models are not foolproof, but there aren't great alternatives to trying to base what you're going to do off of what you think is going to happen.
Okay. So there was a comment that people are not seeing the questions and answers. I'm going to work to go through here and use the send to all button, and I think that'll make that available. While I'm doing that, Cole, I don't know if you feel qualified to answer this, but it said, I've heard that high doses of vitamin C have been successful in some areas, China and New York. Have these been tried in New Mexico? Is that something that is an option?
So vitamin C is really complicated, and I will 100% agree that I'm not qualified to answer the question fully. And I don't know if anybody is, because vitamin C, while it is one of the most studied things in immunology and virology, there has never been anything conclusive about it. It seems to always have just enough of an effect to get someone to fund research on it for another 10 years. My virology professor always had the saying, and this was about influenza, not about COVID-19, but he would always say, I love vitamin C. It's my favorite placebo. So if you think vitamin C works and you're taking vitamin C, there's some evidence that just believing it'll work will help. But I do think there have been patients that doctors have administered vitamin C and then they made good recoveries, and so the doctors say, well, maybe there's something here. Let's try this in a trial. But certainly vitamin C has not been shown in a phase 3 clinical trial to improve COVID-19 outcomes. And like anything, any one of those treatments that has been shown some anecdotal impact, but has not been shown in those large trials, I would caution against putting any sort of faith or stock in it. We just don't know that it works. Vitamin C has a lot of different pathways and stuff that it can work through, and it is an important vitamin for your body. And so I don't want to get too much into the biology of why vitamin C might work, because we could be here all week. But that's just to say, don't put all your hope in it. But as far as things that you could go, vitamin C is a very harmless thing to take. So, yeah.
Okay. I will try and summarize that. I did manage to send all the other questions and answers out. This is an important one. I know there won't be coffee or food set out, but can we bring our own coffee in travel mugs? Dan, are you
That's all you, Chris.
Yes, you can.
Bring your own.
You can bring your own mug. Make sure it's a covered lid. on that you can keep covered, not an open thing that could spill or anything like that. But yes, you can bring your coffee with you. Not a problem at all.
Woohoo!
If you bring extra, we prefer mocha. That would be great. Grande mocha, 2 pump.
The next question is blood plasma being used in Albuquerque? Can blood plasma be a kind of vaccine? And so I will tell you all three, UNM, Lovelace, and Press, have open IRB trials for convalescent plasma. Tricor and Vitalis Blood Center are collecting convalescent plasma. If you believe you have been positive for COVID, or you've been tested positive for COVID and you have recovered, it would be a wonderful thing to go and ask your doctor for an antibody test. And if you're positive in antibodies, to donate your plasma. We think it's a very effective treatment. I'll turn that over to either Chris or Cole if you want to talk more about why we believe it's effective. And we are not going to be using it prophylactically to try to infer some kind of immunity. There's no science to say that would infer immunity. We are using this primarily for very sick ICU-bound patients, usually ventilated, to try and alter the course of their disease. Chris or Cole, anything to add?
Cole?
So in layman's terms, what the theory behind blood plasma is that you're taking a bunch of highly trained troops from someone who's fought this disease and seen it and putting it into somebody who is currently fighting it for the first time. The thought is that if the person who was healthy was able to fight it, their troops, their white blood cells, their immune cells will be able to help the other person fight it. That happens. That seems to work. It's not actually the white blood cells. Sorry, I misspoke there. But it's the antibodies and whatnot. But
antibodies associated.
What was that?
The antibodies associated with the blood plasma.
Associated with the blood plasma, exactly. It's not because if you put white blood cells in, they'd attack the other person. Anyway, this is speaking spontaneously about things. But the bottom line on why we're not going to give plasma to everybody is, as my dad said, blood plasma has to be made from individual people who have come into contact with the disease before. And you actually have to have a lot of people who have come into contact with the disease to donate their plasma to help one person. So it's not going to ever be, or at least not for this epidemic, probably going to be something that every single patient gets, or that we could ever do on the level of a vaccine, and not that we think it would actually help people as a vaccine. But for individual patients who have really bad outlooks, it does seem like there's a lot of evidence that it would be able to produce better results.
It's strictly in the acute care aspect of it. So, but it's still not a bad idea if you want to, donate. I know Vitalant is, as you donate, are checking that to see, even if you're asymptomatic and never know, they're checking for the antibody as well. So, and then they contact you to see if you would continue to donate.
Chris, while you're speaking, I'm going to give you another question, and I'm going to actually take some editorial rights and add to the question. The question is, should healthy people be tested? And so I'm going to add that to NP swabs and antibody testing.
Go ahead. Add to it.
No, I did. So I'm adding to it. Can you differentiate? Should healthy people be differentiated for active virus and through an NP swab? And secondly, should they be tested for antibody?
Well, for right now, it's real for the testing and the stuff for the antibody. We really want to see what the previous positive cases that have shown up positive and try to, and then extrapolate blood after they've come back as a negative to do the test for the antibody. Whether everybody healthy should be tested or not, it's kind of hard to say because, when you start inundating a testing facility, whether it be Tricor, Quest, or wherever we're sending these things to, with a bunch of healthy, it makes the turnaround time slower to get results back, because if we're only testing those that are showing symptoms right now, it gets those people tested, resulted, and treated quickly. So when we start doing masses of groups, it gets really tough to get the thing tested and done. Like if we're doing 6,000 a day and we start increasing that to everybody, it starts slowing down the turnaround process, because there's just not enough scientists to do the tests. There's not enough of the reagents and stuff like that we can do. So we try to manage with the people that are sick right now, but I know there's lots of places that are doing mass collections. I just got a call this morning that somebody just dropped off 3,000 samples to one of my sites for ordering and processing. So we're not turning those away, but it's just like we'd really rather only be testing those that are symptomatic right now.
So our governor would like for all employees to be able to be tested. What the medical advisory team has asked is that we do that in a very studied way. And the issue is that if we start to delay the labs, you not only delay care in acute care settings and use up capacity for ICUs while you're waiting to make the right clinical decision, but you also delay the response to an outbreak, say in a nursing home. And then that 2-day delay in a response because the testing equipment was all overloaded and backed up, or we were out of testing kits or reagent, causes deaths. And that's half of New Mexico's deaths have been in nursing homes. We've got to be smart about how we test, and it shouldn't be everyone in a business. It should be a percentage of people in a business, and then it should be, because it's a point in time test. And so one test today says nothing about you 96 hours from now. Right.
Exactly.
So we're now going to move. We've just got a few more questions. We got 24 more minutes. Dan, what are the rules for non-Sunday morning meetings, i.e. Bible study and other group meetings at the church facility?
We're not starting those until we've had the first service, because we still have to get everything kind of disassembled from other stuff that we were doing in there and cleaned up and set up. And so we will probably be allowing those meetings around the first of the month, but that has not been set yet. The only ones we're currently allowing, other than our church group, our normal Sunday morning there is, I've told the youth to let us know when they want to start. They don't have a date yet. I told Tom Lamblett, whose church meets there, that they could start meeting when we started meeting in the evening, but they would have to follow all of our protocols for having the place cleaned down the same as what we do. And right now, that is it. We haven't opened the door for the other groups yet. And I think we may, haven't talked to Chris about it, but we may just want to wait and see how a Sunday or two goes, and then see what we want to do with that NX room.
Right. All right. And then the last question I have in now, you can still enter more questions if you have questions, I opened this can of worms earlier, I apologize. If singing is a risk, will worship be cut shorter? I opened this and I didn't finish it. The study in Seattle, basically 63 people attended a choir service rehearsal for 2.5 hours straight. They were in a choir loft kind of setting, all very compressed, and they sang for 2.5 hours, creating a lot of droplet and a lot of aerosolized virus. There was one index symptomatic patient, and ultimately 32 people from that choir were confirmed positive. Another 20-something were presumed positive. And then you had 3 hospitalizations and 2 deaths, all from that one choir rehearsal. At this point, if you go on that medical advisory team resource on the governor's COVID-19 webpage, on the DOH webpage, you'll see the medical advisory team recommendation, and it actually comes from a set of global and national barbershop quartet societies, choir societies. It is not just something being made up in New Mexico. But singing is a uniquely aerosolizing activity. And so it does need to be taken into consideration as to how we sing safely, how we distance, do we mask, all of that. So with that, Chris, has the clinical advisory team been able to deal with that yet for our church?
Well, I think it's on the fact of we're limiting the amount of people that's even actually on the worship team up there at any one time, and we have to practice the 6-foot distancing there on stage, and plus we're well over 6 feet from any congregational member that's out there, so reducing it immensely just by the distancing is what we're going to do, and minimizing the amount of songs that we do. I know that we will not be doing 4 or 5 different songs at any one time. So sorry, my other phone's ringing. But I think we're limited to 1 or 2 songs for now, and limiting them out no more than 5, because once you get more than 5, we can't safely practice 6 foot between each member up there, since I do play up there and sing, that we limit that. Now, I don't, whether we wear masks or not, now we've got to make that another decision on that. But if we're practicing 6 foot, I think we're going to be fine with that.
Okay.
Because
we're
like the first person that's in the line.
I actually asked the fire marshal about that. We were just talking about how things work out, and we had to ask him out to ask how many people could be in the annex, because we don't have any signs up in there or the youth room, and he said absolutely fine for whoever's leading the music or the speaker up there. He didn't really say anything about other people who are in the seats, even though we're far apart. I didn't ask about that. And we're also going to try to keep our services down to an hour. They're almost exactly an hour week to week now online, and we're going to keep them at that so that we have a full half hour between the services to get everything cleaned out. That's another reason for shrinking the amount of music. Yeah.
A clarification that came in, it said, did Clay say that over 50% of deaths have been in nursing homes and over 50% of deaths on the Navajo reservation? No, those are two different statistics. Thanks for calling me on that. 50% of infections have occurred in tribal populations, not just Navajo, but total tribal populations. We have, I forget the count of total tribal populations in our border. But over 50% of deaths have occurred in confined populations, in nursing, assisted living, and other confined populations. So two different statistics. One is infections, the other is deaths. And they do overlap. A number of those tribal affiliated deaths did occur in nursing home populations. So that's where those statistics come from. Looking for additional questions out there, and let me scan one more time and make sure these all have check marks next to them. Regarding singing, it would help to have doors and windows open or somehow getting air to be circulated out of the building. I'm going to just send that one to Chris privately, just for his group to consider. I don't think the windows near the stage do not open. Didn't hear a clear answer on this. Will people in the congregation be allowed to sing? You're on mute, Chris.
Well, of course you're going to be able to sing. You'll just be singing through a mask, so you'll be singing a little lower tone. So we encourage worship, but just practice it with a mask on, because even amongst yourselves, close by. So yeah, we're gonna recommend that, yes, sing, but do it with a mask on.
Great, thank you very much. I'm scanning up to see if I've missed any more. Do you know how much an antibody test costs? In the state of New Mexico, your insurance, if you have insurance, will be billed. And Chris, you want to answer on patient responsibility?
It depends on your insurance. On the antibody test, to do that, it is an out-of-pocket expense. Whether your insurance will cover it, you need to find out from your payer source there on what it is. The cost, I'm not privy to the billing portion of that, but it's not exactly a cheap test. I'll just say that, because it's fairly new, and anything like that, it's limited on what we do. And like I said, the antibody tests, we're only doing that on people that have been tested positive, and now they're doing it as a negative to follow up with that.
And the other type of testing, the nasopharyngeal swabbing, all the government entities have said that is free, and that's a little misleading. The third-party payer is billed, but the patient responsibility is then billed to a governmental entity, and so that's how that occurs. It's free to you. It is not free. Is that true, Chris?
True. Yes. We don't bill it to your insurance. We bill it to the third party, and then it goes to, we then bill it to the government on that for what we're going to get reimbursed for. And for any of that, it's minimal on what we're getting reimbursed.
Okay, when do you expect a second wave? Let me start this one just by saying that the models are very good for 2 to 3 weeks out. After that, there's a lot of variability around what happens when we reopen. Do people really wear masks in public? Is there a lot of travel that occurs? I mean, there's a lot of variability. The current model shows a slow building of hospitalizations and ICU utilization that does not completely overwhelm the system, keeps us in a high contingency level of care for the next, for the next 20 days, a peak at about 70 days, and then a second peak at about 170 days. So that's the current model, but I will tell you, when you get out beyond around 3 weeks, there are a lot of variables. Cole, anything you want to clean up on that one?
I think that it's just one of those things that's going to be very difficult to predict because it's so dependent on what the public ends up doing and what our officials decide on putting as public policy. Models are very good at predicting what's going on now, but once one of those things changes, the model has to change as well. And so predicting when a second wave is going to happen, I wouldn't even say necessarily a second wave will happen if we've managed this properly, but a lot of places won't. And so a second wave will probably happen in a lot of places, but when will it happen? It's really hard to tell. It's about how they handle it.
Okay.
And it all depends on how well we comply and doing our hygiene, social distancing, and masking, and just eat your piece so you can go out and play. It's just like we have to do these things so that we can have some freedoms out there. So it's just in practicing what we're supposed to be doing, which will affect how that model goes.
Okay, Jennifer Bryant just sent out an answer for the antibody testing. I assume she's right. She says $120 without insurance. So I sent that out for people with for what it's worth. Regarding, is it true that viruses prefer cold?
It's so much more complicated than that.
I'm just going to say no.
Yeah, no.
There's many variables. Cold can tell you
that. The observed folk knowledge, I guess, about viruses and cold probably has more to do with people huddling in winter months and congregating in buildings together, but probably doesn't have as much to do with the temperature.
All right. We have gotten through all of the questions that have been submitted online. It is 47, and the dogs sound upset. Dan?
Mine's a dead one back there.
All right. Dan, anything you'd like to say to close this out?
No, I'm kind of puppy barking in here. It's all right. No, can I close this in prayer? Does that sound good?
That'd be super. Thanks.
Okay. Father, thanks for letting us get together. I thank you so much for giving us people at AnchorPoint that are so in the middle of this, that love you, that love others, that want to keep us safe. And I just ask that you would bless them. Thank you for them spending their time tonight. I ask that you would give them a great time at home with their families, and that you give us wisdom going forward. Father, we love you, and we want to love others. Help us to do that well, and we look forward to seeing you one day. In your name we pray. Amen.
Amen. Everybody, this session was recorded. Hopefully we can figure out how to retrieve that recording and make it available. I would say probably not before midday tomorrow. And I'll send it over to Dan and he can try and make it available to the office. Okay. And thank you, everybody. Really appreciate the opportunity to share. Take care.
Yeah.
Love you. Bye. Bye. There's so many